Good afternoon, everyone, and I'd like to encourage everyone to get back to their places, and we can start the afternoon session. It's a real pleasure to welcome Beilu, who's going to talk about changes in morbidity prevalence in China. I would say, I think, to me, one of the greatest achievements of the last century has been that we're not only living longer, but that we're healthy longer, and that aging is good news from the morbidity perspective. I'm slightly worried that this is not going to be what she's going to say, and that would actually be quite frightening. But let's welcome her, and let's see.
Thank you, David. Thank you, Karen, for having me here again. It's really a pleasure to be in Stanford. So before I came, I went through all the papers Karen had put onto the Dropbox, and I was quite embarrassed because my one was the shortest. Not only the shortest, it was only like half of the size of the next shortest paper. But nevertheless, I think I'm addressing 20% of the elderly population in the world, and at least two of the very relevant questions about getting older, because when you get older, you need money, and all these public or private money comes from pension, health, consumptions, and long-term care. So this health trend in China for the aging population at least has something to do with the health expenditure as well as the long-term care demand and consumption side in China in the near future. Let me get on to the overview presentation. So the overview is quite simple. The first part is the overview, which we're not really including in the paper because I think I need to have some background to all the audience here. What's going on in that 10 years period of time in China in terms of the aging population in their income and resources of income. And then it comes with a real part of the paper, which is begin with the literature and the motivation of this paper. And then we present the data, the model, the results, and some policy indications at the end. So the data was same from the SSAPUR. We call SSAPUR. It's longitudinal data done by the Aging Committee. Is a government body formed both from the Ministry of Human Resources and Social Security as well as Ministry of Civil Affairs. But it's not a public, it's not an open access data set, so we have to get a special permission to use this data. But I think the quality of the data is quite good. So it represents the changes of the Chinese elders in those period of time. So in the income trend, in the urban side, you can see that between those 10 years period, it's tripled the income. And same thing happened with rural as well. But there seems to be a 10 years lag between rural side and the urban side. So the 2010 rural income, nominal terms, is equivalent to the 2000 urban income level. So it seems for the rural to catch up with the urban, it takes 10 years time. But the income increase is about the same speed. And the line is the national average income. So the elderly population actually have quite equivalent income level as the national level. It's not really much lower than the national average level. And we have some urban to rural ratio. It seems quite, it's improved a lot in this 10 years period of time. And then if you look at the consumption, it's basically about the same, except the ratio doesn't change much from 3.27 to 3.17. It's all about 3 times more like those period of time. So the net wealth only comprise the property price and their savings. The net wealth per person, this is not per household, so we divide by the household size, is quite dramatic. In the 10 years time, it seems to be increased by more than 8 times in the urban sector. In the rural, it's not much as urban, but that's where the urban and rural residents have huge gaps from now on, from that period of time. In China, housing is by far the main asset for the older households or older generations. And the saving is really a very minimum part compared with the equity in the household. And there's very little debt. So that's a basic structure. And in the net asset terms, urban to rural ratio increased, like doubled, from 3.6 times up to 7 times in 2010. And the resources of income, even in the urban sector, in 2000, about 50% of the elders rely on their children, but in 10 years' time, this ratio reduced to 15,000. And in the rural sector, used to be 80% elders living on their children, and now it's only half, 40%. And the major changes are from the government pension. So government pension takes like 56% of the urban elders' major income, and almost 30% in rural now. So there's a big difference in those period of time in China for the aging population. All right, coming back to the presentation today about health and mobility trend, and there's quite rich literatures about health trend, starting from Fries, who presented these 3 theories, the important, famous 3 series of compression, expansion, and the dynamic equilibrium. So basically, the compression of mobility, saying that the declining in mobility is associated with similar improvement in mobility or disability. And then expansion, of course, is the other way around. And with the recent one, most recent of the 3 is the dynamic equilibrium. So a portion of the gain in life expectancy is accompanied with a smaller portion of the gain in the disability status. So that presents a dynamic health picture. And the very recent literatures in the world shows quite contradictory or different views on health trend. So Carol Jager has been studying this for more than 20 years in UK, and she found the recent in England, there's an absolute compression of cognitive impairment, but dynamic equilibrium of disability. Less severe disability is increasing, but more severe disability is not. Actually, when I go on, China, from our paper, is different from that. And in US, the Crimeans find that the empirical findings do not support recent compression of mobility. So they're using the US data from 1998 to 2006 for age 60 above. Able to function years had decreased, both for men and women in 2006 compared to 8 years ago. It seems to say that the health status has not been improved in those 8 years. But thanks to Karen, I just put in after Sammy, that's the Cutler in 2013, using the Medicaid data set. They showed a very strong evidence for compression of measured disability, including IADL and ADLs of functioning ability using this data set for the almost 20 years period. Having said that, I must emphasize that it's very normal that the results are different, because almost every paper uses different set of scoring or different set of catalogs for determining which group is healthy and which group is disability or mobility impaired. So you really have to turn to the original paper to see what are the catalogs for those people who are included in the disability or mobility groups. In China, there's also a bunch of literatures on the mobility and health. So in 2006, Gu and Zheng found that ADLs in China for elders 65 has declined by 1% annually. And Du and Wu in 2006, they discovered that actual ADLs was increased from 7.5 in 1994 to 8.9 in 2004, using the Bureau of Statistics data. So this is already quite a contradictory result. And then in 2009, Liu et al. Says that 1987 and 2006, severe disability was declining in that period. And they compared the disability-free life expectancy using the actual clinical national data. This is quite large data for almost 500,000 samples each wave, and find a trend for compression of mobility among the oldest Chinese people. And the most recent piece in 2015 by Law et al., and they used the CHARLS data in 2011, but compared with CNHS in 2000, and they showed that the active life expectancy from 2000 to 11 years later had declined from the 83% to 81.6% in women, and then even larger in men at age 55. So why, having all these results, why we still want to do some research on that topic? First is because this data is quite new to most researchers, but I think it's quite valuable having the 3 waves of the longitudinal data in China and organized by the government body. And but we really want to investigate changes in mobility preferences among the elders, again, using a new data set to confirm if any of these previous literatures have shown, because they all show different results. And including the gender, because the previous one does not really give a lot of options, and subpopulations. And then we to explore the correlates of unobserved mobility trends by focusing on selected social and demographic factors. We want to do a little bit more by finding out what are the drivers for having more or less disability or mobilities. And then we estimate mobility-free life expectancy for the 3 waves for both men and women using the Sullivan sample. All right, so I've already talked a little bit about this data, and we used 3 waves in 2000, 2006, and 2010, and each wave consists about 19,000 samples. And it's actually 2015, they've done a much larger scale of sampling for 200,000 plus, but it's not available yet. So we can't get access to that. And the screen shows how it's a remote access, and it's constantly dropped. So it's really getting frustrated at the later stage because the server is so slow, or sometimes they just shut down for 4 or 5 months. So it's not easy to do this analysis based on this data set. The survey focused on social, economic, and health character. So it has almost all the HIS questions regarding the income and the health status. And it's nationally weighted as well. So all the results when we present are actually weighted in the national demographic figures. And I have to emphasize our definition of health, because I said that if you use different categories, you get different results, and that's very sensitive. So for IADLs and ADL questions, we have 0 point if there's no difficulty. But we have 1 point if there's some difficulty, and have 3 points if you can't do it. That's how they ask a question in the survey. And health status I catalog into like 5, but we mainly concentrate on the 3 later ones. So a healthy one are those without or with only 1 point of IADL. And the CD is a chronic disease. For the first wave in 2000, they only ask 1 question whether you have chronic disease or not, without listing all the chronic disease types. So that limited our analysis on chronic disease to some extent. And then we define mainly the minor, basic, and severe mobility according to IADL and ADL scores. So with 2 to 26, altogether there are 36 IADL scores. If you have more than 26, we catalog them into basic mobility, the same as having at least 1 ADLs. The severe mobility actually has 3+. Using 3+ is that we investigate almost all the eligibility for long-term care public programs in China. It's equivalent to 3 or 4 ADLs. So we think that might be a good benchmark for high care in long-term care system with this ADL impairments. So the minor mobility consists of people with ADL impairment. It seems in the 10 years period, except only one age group for 80 to 84, all age groups have been consistently growing in terms of prevalences of ADLs. And the national data in average is also showing kind of 1.5% of increasing in the ADL prevalences. And the next one is the basic morbidity, which is 1 plus ADLs. It shows a different pattern of prevalences. For all age groups, except the latest 85 plus, it's been compressing. So there's a general improvement in the ADLs, except those age 5 plus groups. And in general, if you look at the national average for age 60 above, it's actually showing a declining in the percentage of the prevalences of ADLs. But when it comes to 3 ADLs plus 1 chronic disease, then there's an uneven structure with each age groups. But one thing is quite obvious, that with 85 plus, there's a sharp increase in the severe disability in 2010 compared with previous years. So this picture just gives you a general idea about how it moves. And the average scores for ADL confirms that trend. So if you look at the weighted numbers, it shows that these are the people who have already had ADLs. So in this 10 years period, the ADLs have been increasing scores. So it shows the severity of the disability has been improving, even though we showed that the prevalences of ADLs has been declining. And just to compare the robustness of the statistics, we compare with 2011 CHARLS data. The ADL 1, 2, 3, which they define, is like 1 ADL, or 1 and 2, and 2 and 3 in ADL 2, and 3 and 4 in ADL 3s. So ADL altogether in CHARLS comes up like 10% of the population, while in our sample is only about 8%. But the very severe group with ADL 3 plus, it seems to be quite close. With ADL 2 and 3, they have 1.5%. So it's quite consistent with all these survey data using SSAPUR. We talk about chronic disease. I have to put something just to reflect a little bit of statistics. So chronic disease has been constantly increasing in terms of prevalences. But from 2003 to 2009, China implemented this new new rural cooperative scheme insurance. It's a medical insurance to cover all the rest of the population without employee medical insurance. So we believe part of this increase is because of the diagnosis rates has been increasing and improving for the chronic disease. That's why we do not put some emphasis in the later analysis. And maybe something interesting would be related with long-term care is the dementia and the Alzheimer rate. You could see that both men and the female has a quite sharp increase between 2006 and 2010. That's where the data is available. And this increase is also accompanied with the disability ratio. So this blue line, the gray line, is the cross-tag with those who claim have dementia or Alzheimer who has ADL 1s and ADL 3s. And then we plot all the age-specific disability ratio. I just want to show a little bit for the urban ADL prevalences. For example, you could see quite clearly already with the statistics plots that the prevalences of ADL has been reduced from age 60 to about age 85, a great deal. And compared with the red line is 2010 years ago. But all these later stages have been going up quite dramatically. So by all these statistics, we can almost conclude or approximately estimate the numbers of people who will be in some kind of social support. So about 54 million elders need some kind of social assistant, with basically family assistant, to help with the IADL, minor help. And about 17 million elders need kind of low care with 1 ADLs. And about 3 million need very intensive care, possibly in the long-term care, nursing homes, or intensive care facilities. So the next, we want to just to explore a little bit about what drives those changes. So the model we apply is simple. We just use a random effect logic model. And it's actually a two-stage with the other. We only focus on the ADLs because if you do the severe ADLs, 3+, it will generate very similar results as the ADLs, but it excludes actually the what we're trying to find out. So we do the stage 2 is exclude those who are healthy, with those only ADL 1+, who are the most severe ones. So we used a score instead of the random logic model at the second result for the coefficient thing. So if we look at those independent variables, it's very understandable that the older you are, the more likely you'll be disabled or you're having ADLs. And the high income you are, the less likely you have probability of morbidity. And education plays a major role in reducing the morbidity or disability. And the male tends to be less likely to be disabled than female. And then married as well. All these listing, we exclude all the insignificant parts. And with rural, the new cooperative medical insurance scheme, there's a positive effect on reducing the disability as well. But this is quite common. But if you look at the scores, once you have ADL, who are likely to be more severely disabled, they are almost all opposite in the coefficients. So except age, you can't change the age effect. For long income, the more money you have, maybe the more likely you can extend your life in severe disability status, as well as education and marriage. Almost everything which in decreasing the prevalences of ADLs are now becoming a factor to increase the severity of the ADLs. So those two effects might be related with our next stage results. So we try to estimate those statistics using the SSAPUR, using the Sullivan method. And we did some adjustment for the mortality table, which was published by the Chinese Bureau of Statistics, because those statistics can't match the announced life expectancy. So I don't go into details how we adjust all those mortality tables. And also for Chinese literatures, if there's different results, I think more or less are derived from those mortality rates applications, because they're just so different when you apply for different ones. So that's the result basically from, if we catalog them into male and female life expectancy and the disability life expectancy. This is too hard to read. So we group them into this table. For the life expectancy, the national-wise, it's gained by 0.8 years in the 10 years' time. And urban are the far gained under the rural sectors. But if you look at the mobility-free, this is the basic mobility-free life expectancy at 60. The rural males are actually the party which should be focused on, because they really gain very little in life expectancy, and they really didn't spend much time in disability as well. They need a lot of support, which means they die very soon once they have some disability, and which they don't improve much in the 10 years' time. It's partly because the healthy older ones are moving to the city side as well. So someone said you can't really use rural and urban during those 10 years to compare the actual phenomenon, because a lot of people are migrating to the urban sector, especially those healthy ones. So we generalize all the data, but we use another catalog with age groups. So at age 60, it seems that all the life expectancy for man and female combined, urban and rural combined, all the mobility-free life expectancy have been improving, along with the life expectancy at age 60. But at age 80, it presents a very different state in the basic and the severe mobility-free life expectancy. It already showed a negative gain, which indicates that the majority of the life expectancy gain are not healthy when you look at the age 80 groups in China during those 10 years period. So that's kind of depressing in a way. If we come to a conclusion that over the 10 years period from 2000 to 2010, then there's an expansion of minor mobility because ADL preferences have been increasing consistently over all age groups and over the years, but a compression of basic mobility. The ADL 1+ really showing a quite strong decreasing over the period and for all age groups except age 85+. But there's an expansion of severe mobility. And it's quite obvious in the later ages, 80, 85, there's a sharp increase in the severe mobility status. But if you look at the age groups, there's a compression of basic mobility in age 60 to 79, but there's an expansion trend of mobility in all oldest old groups. So it's almost, for oldest old groups, there's already an expansion of mobility in China. And these are consistent with the minor, basic, and severe mobility life expectancy has been increasing, but less than total life expectancy at age 60. At age 80, minor mobility life expectancy similar to age 60, but basic and severe mobility are more than total life gained at age 80. Well, that's not the end of this paper, because I think the more important thing is what are the implications of these findings. In China, the aging is so rapid that it can almost dissolve all the minor changes in percentage of people in terms of their health status. So if we look at this population projection from 2010 to 2015, 40 years time, you could see the black line here is a group of people with age 60 to 79. So there's a sharp increase in the next 15 years is belonging to this youngest old cohort. And there's a minor increase for the 80+ cohort until 2035 something. But from 2035 up to 2050, the next 15 years, there will be 3 times more of the 80+ groups. So the 80+ in China, according to this model, will be more than 100 million people in China. If this trend continues or cannot be improved dramatically for the 80+ expansion of mobility, then there will be a huge demand in China for long-term care. Not to say that these are the people with only one child, and the informal sector cannot be relied on absolutely. So the policymakers really should be aware that there isn't much time left for, especially for the severe mobility cohorts to be coming. There's a huge wave of people waiting to be cared. And if you look at this map, so the healthy part, the minor mobility part moves a little bit, this is leftwards, and the basic ADLs moves a little bit rightward. And then with the severe ones moves again leftward. But those numbers cannot be compared if you look at those 10 years period growing from 120 million to 180 million in age groups in the same 60 plus population. And if you add more to 2050, then they will be reaching 400 million people. So the percentage change is not really the most important thing anymore. I think what implied is we should focus on this healthy part, which will increase even more. And there should be policies really encourage people, healthy, younger, old people to work longer. And that's basically the end of the presentation. Thank you very much.
Thank you. And I'd like to invite Wang Feng, who's going to be the discussant from Fudan University and UC Irvine. Thank you.
That's really interesting. Are you leaving
tonight? Good afternoon. Thank you, Karen, for putting this excellent workshop together. I know how much work it takes, and thank Lu Bei or Bei Lu and your colleagues for this excellent paper. I gave a title, even though I think as Bei Lu reviewed, literature for China and for elsewhere has actually produced inconsistent results. I still think this paper is so important, and we want to really know whether this is really, we have something very major going on. That is, as the economy improves, as healthcare improves in China, we are seeing something that's going the other way around. Okay, so this is a paper that really makes, I think, very important contributions. Given the rapidly aging population, that I think we all know that the number is going from about 200 million today, ages 60 and over, to in about 15 years to about 400 million, 300 million people. That's larger than the size of the United States. And we're talking about 1/5 of China's population. So just in a matter of less than 15 years. And the implication of this large aging population for Chinese, the world economy, and for health and needs for all kinds of things, for medicine, healthcare, long-term care, as we're discussing here. So this is enormously important. We already know aging pretty well for China, but in terms of health, we don't know nearly as much. So this is really an important paper to provide important information for that missing important information. So the paper, as the author just described, used data from 3 waves of a large-scale national survey during a 10-year time span, and looks at 3 different types of morbidity, and also calculates the morbidity-free life expectancy, and then with the multivariate analysis, looking at the factors affecting ADLs. Well, the results are not very encouraging. That is, life is not getting better in some aspect at older ages. Basically, I'm just repeating what was just presented. In terms of the 3 types of morbidity, with the exception of basic morbidity that's compressed somewhat, in the other 2 groups, they are both expanded, meaning morbidity increased over this 10-year time period, and also the increase in morbidity-free life expectancy did not catch up with increase in life expectancy in general, right? So overall, we are looking at a picture like this. Now, given this is very important, it's so important. So the first thing we want to make sure that everything is nearly airtight. If not airtight, it's it's robust. So I like this paper very much. It has every part. I thought my contribution or my gratitude to the authors is to ask questions and to see whether we can be more certain. So the first question I have is really about data. I think I figured out during your presentation that this is really not panel data. It's because I see no attrition. I saw the, for 3 time periods. So that actually makes the whole study more challenging because we're not actually looking at the same people over time. These are 3 cross-sectional surveys. And in general, surveys are getting so much harder to do in China. I will still use, we have to live with what data we have. But before, I would be 100 or 95% certain with this very important negative results, I would look at every aspect of these 3 waves to look for issues of data problems. For instance, what about attrition, right? Could the pattern we observe here be caused by the issues that's in these data sets? I think with more time, when people play with these data, because they are not panel, you would be able to see to what extent they are credible. As the great demographer Ansley Cole once said, all data are dirty until proven otherwise. So that's how we proceed. And this is very important because you can have, you already have a lot of age-specific rates, and those rates are more subject to data problems because they are, were smaller ends. And those rates are used for live tables, which will come up. The second issue you noticed is about measurement. And in the paper and in the presentation, you explained what happened in China between 2003 and 2009. There was this new cooperative healthcare program, and exactly what we also saw is the increase in chronic disease that just jumped from 59 to 72, and then from 52 to 66 for males and females between the first 2 time periods. And there's not much change afterwards. So how much of this was really due to, as you said in the paper, because of the healthcare program, people are more aware of their diseases, and also because of other, treatment and incentives. And I also just noticed during the presentation that a lot of these changes are really for people who are over the age of 85 and over. So that actually goes to the third point, which is in table 3, which you present the overall overall rates for males and females for different types of morbidity. I would do at least the age standardization to make sure that these are the changes in rates, not because of the changes in the sample over time. Right. So there's all kinds of things we can look at data and methods to make sure that these numbers are robust. Then I want to say more about data because one of the important conclusions is that life expectancy improved faster than morbidity-free life expectancy, right? Here, I'm just re-showing the table that Rubei just showed. In the 10-year time period, if we look at age 60, it's 4.3% versus morbidity-free life expectancy, that's 22.3, 3.8, 3.3. They're all lower. And the same thing happens at age 80, right? Now, the problem, though, potential problem, is we can't trust the life expectancy reported by the Chinese Statistics Bureau. Okay. So if the life expectancy increase was not as fast as, like say, from what you used early on, then the morbidity-free life expectancy may not have fallen behind so much. Now, what I'm showing here, this is from Cai Yong's work published in PDR in 2013, looking at various life expectancy. Let me show you here, just highlight life expectancy at age 40. And this is unadjusted, right? So that's about 4-year increase, right? And here, this is for females. It's again, here's less, about 3-year improvement. But here, using a method that I would not go into, it's called a general growth balance model. You see here, the improvement is less. It's about a year less. Here again, it's about a year less. So depending, you can look into this and look at different estimates of life expectancy increase for China, and then see whether the comparison could be made more confident. Why? This is what happens with the Chinese census. It looks awful. This is the survival ratio between the intercensus survival ratio between year 2000 and 2010, the two censuses. The survival, we know people don't over-survive, but at younger ages, for males and females, for Chinese here, the survival ratio excess is over 20%. So 15-20% people appeared more. That does not affect, I think, your results too much, except they do affect, without adjustment, they do affect life expectancy at age 0, because these are impossible, ridiculous numbers. There are many reasons. These are not, not known issue because of underreporting of children at earlier time, and they appeared, and also because of the way that the Chinese census did in 2010. They counted people both at origin and at birthplace, and then they used some kind of formula to do this. So there's, among young people in these ages, 10, 20, there's actually, survival ratio cannot be 1 either. So there's a lot of migration that's built into this. So there was a major, I'm just getting a little sideways, there was a major kind of sensational report saying 75% of Chinese missing girls were actually not missing because they were not counted. And that actually, that report was picked up by a lot of news media, and it's actually problematic because they did not realize that 2010 census also has its own problems. I think what's relevant is really at old age. Look at here. These are the top and the bottom lines are the life table survival ratios, and the government, the intercensus survival ratio between 2000 and 2010 for females, for instance, is very close to the life table survival ratio of 2000. So this means that it should be closer, either in the middle or closer to 2010. So there could be underreporting at old age as well, and that could cause a nicer, rosier improvement in life expectancy. But these are all kind of small, in a way, small issues to say that we could have problems with census, we have problems with survey, before we are absolutely sure that this reversal is happening. Let's look at this data more carefully because they are all problematic. So to conclude, again, this is really a very important, timely study of a very important issue with multiple resources, and the findings are very important. But we really need to look at both data sources, whether the census are too good and the surveys are too poor, or there's no such a thing. And there are two issues that we would, should you be certain that these trends are true, then we would have questions to say what happened. And that is something that I think can be discussed in the paper and in the future with other sources, right? Why would morbidity increase, right, over time? So I think we would want to know the causes and also what are the mechanisms, right? So, and you can certainly go more in the last stage of the paper where you did these projections, but this could be for a different paper, because in the survey data, you actually also have household composition. You can look at the need for long-term care or the pattern of morbidity by household structure, given that 1 in 3 Chinese families will be an only child family. We can also look at the needs really for long-term care, because that would also depend on the family structure. So there are a lot of other more things can be done, but again, this is such a kind of baseline important paper. I just want to raise questions about data. These are not your responsibility, but we work with them. But there are possibilities that they could pollute our results. But again, thank you for a very good paper. Thank you.
Would you like to respond to those points before we go to questions?
Maybe just briefly, I think the data actually has half of the sample is longitudinal, but because there's the way they present the data is so poor, we have to manually adjust the IDs to make it a panel data. So we gave up at the end, and because the server is so slow, it's just impossible to trace it. So yeah, if they open up the data set to some extent, we could really make it a panel data. But at the stage, we treat all the samples as a cross-sectional data. Yeah, we are fully aware of the life expectancy, the mortality tables. So that's why we do some adjustment using some guidelines with a published paper for Bai and whatever et al. They use their way to adjust all the mortality at later stages. I think China has many problems of mortality reports because of the deaths, because of the huge migration, and people who died in a place without their hukou, without registration certificate, will find it difficult to be registered as deaths in their hukou registration place. And that will cause some fluctuation in the death report. So after we adjusted, I think it makes more sense for that age group in those years to grow. And a large improvement of the life expectancy actually happens before 60, before 2010. So we'll do some further work, as Wanfen suggested, to compare the life expectancy, the mortality table we're using, and just to prove it's robust enough to present it later on the disability-free life expectancy results. And that's why we actually put a lot of emphasis on the statistic rather than the final disability-free life expectancy results, because we do feel that that would be a big problem for the mortality table usage. Thanks a lot.
Questions?
If you look at the title of the conference, it's financing longevity, and you have shown now for China, population lives longer there, but it's not a given that automatically if you live longer, the healthcare status or the morbidity status behaves in a similar direction. Therefore, healthcare policy and the investments into health or the way we are living, if we are living longer, it's a huge topic we have in mind, and as well look if this is true for other countries, or like in India or in Europe or in the US, and if we have a trend that we live longer without appropriately shorter disease-free intervals, financing longevity really becomes impossible.
I think
don't know what, if this is a temporary effect in China, and it's a question how well you have equal access
Yeah, a lot of work could be done to explore this phenomenon at age 80 group, where there shows already a expansion of mobility. We haven't done that yet. I think that could be another 2 or 3 papers already, because there's such a dynamic phenomenon in China for those age groups. People with very good health care could just prolong their lifetime with unlimited public resources. If you're in the public sector, you basically could just stay in the hospital forever until you die without paying anything out of pocket. And people in rural areas, of course, is a very different phenomenon. So it could be partly because of the policy. Once we address this issue, maybe people could focus on this issue and then explore what are the reasons why these people have already shown, in this cohort, has already shown expansion of mobility. If it's because of the health policy helping those public funded people too much, we might adjust the policy to some extent to be fair to the majority of the population, because 80+ groups tended to be wealthier and have better access to the healthcare group of people. So it could be changing in a way, even though the past 10 years showed this, it could be changing. And I think also there's another problem people were saying was over drugs in China. It's not taking drugs. They just prescribe too many drugs to each patient because of the health system was designed in that way to encourage doctors to sell you drugs by making the profit to the hospital. So China is also doing a medical reform. Major reform in China nowadays are medical insurance reforms. This could be reversed. This drug issue could be reversed under that medical insurance reform. So hopefully all these very big things going on in China could change the trend. But I think it identifies the trend in the past 10 years will help to explore deeper why this happened and then try to fix it, especially for these oldest groups, why they've already presented. Because I think in the West, it's quite few countries have already presented compression of severe disability status in the later ages. So why China should be, at this stage, has already been expansion status is quite alarming and should be explored. But I don't think we can fix this in this paper. It's just too much for it.
Hans?
Yeah, thank you very much. Very interesting. The message I took home was this expansion of morbidity among the oldest old. What is it? What was the age group again? Of
80+.
80+. I mean, I don't know the literature here at all, but I would have thought that if you have an open-ended category, that if you're comparing, because you're comparing 2 points of time, right? That you're not comparing homogeneous age groups. That the oldest group will, I guess, with an aging population on average, be a lot older, or it'll be older. Okay, so I wouldn't have been too surprised to see then an expansion of, the expansion of morbidity. I don't know how it's usually done in the literature, but if this is, I'm reading something, I mean, for me it wasn't surprising if it's an open-ended category and you have an aging population that you have an expansion of morbidity in the last category.
Yeah, it's partly because of the Asian population. It's partly because they live longer with longer unhealthy status. So, but in these 10 years, I think the average age of the 60+ didn't increase much. Actually, China will only increase the average age of the 60+ until 2030. So before 2030, it's all about 69 years old. So in that age group is about.
I think the average age, I think what I'm saying is that the average age of the oldest old.
Of the 60+.
No, the 80+.
So between 2010 and 2000,
Yeah.
for 80, given China is aging, people living longer. So if it's open-ended 85, you probably have more 85 and above
that's right.
than
That's right.
in 2010 than 2000, right? That could be.
Yeah, but we plot this by age, by each
that,
age.
But last
and
group is
aggregated.
open. And that group, I saw the the bar charts, that's the group that has the sharpest increase
That's
in
right.
morbidity.
So that's why it's
So
a
we can look
problem.
into that. We could look
That's
into
why
that.
it's a problem. So why they didn't increase the life expectancy at a healthier stage, but at unhealthier stage?
I was just wondering if you really would call that then expansion of morbidity, if you observe that, if you're not comparing same age groups, that's the only thing. But I guess maybe.
Yeah, we could restrict it to like 80 to 90.
80 to
maybe.
90.
You can try that.
80.
Also, with some standardization, that would help.
Yeah, maybe, also, yeah, that's a good idea, because 95 plus sample is very limited as well. It could be biased as well.
Yeah, maybe I can just press you a little bit on this, on the data issue. I think that, and some people have said, I think I'm surprised that you're getting expansion of morbidity at this stage, is that the history of US and Europe basically was compression until quite recently. So this is very early expansion happening in China, if it's happening. I just want to comment on a couple of points. One is, at older ages, there tends to be quite a lot of age misreporting. People overestimate their age. And I don't know if maybe China's got better age reporting, but
I don't think that's a
China,
problem.
that's basically generally not a problem.
yeah, so I think China's got better. But in countries like India and the other countries with records are bad, there's a lot of age misreporting, and maybe you don't have that. But the other thing is, among these people with severe disability, you're going to be getting a lot of proxy responses, and you're going to be getting maybe non-response. And there's also an institutionalized population, which is missed in US surveys. I just wonder, is the population you're looking at really nationally representative? And are you getting actual responses or proxy responses from the disabled?
The weighted system is according to the place and the gender only. So they have a formula of weighted structure of all the sampling. We just use their weighted formula to weight it to the national data. The compression, the expansion at the latest stage, I think in some, because I don't read much about old age groups of the mobility status. If you compare the very severe ones, England actually has some kind of survey data also confirms that trend as well in certain period of time. I think we, like Alfonso, we just have to do more careful work to tease out all the bias in the data set to make a conclusion with that kind of strong conclusion.
Other questions?
But if I can, I already used a lot of time. It's so interesting. Now, in addition to the changes in the healthcare system, which allowed people to stay in poor health and mobility status longer during this 10-year time period, what causes expansion at this age, at such a stage? Generally, what do we know? What are the other possibilities, right?
I think
this is
some
not
of
just
the
for you, but for everyone.
dementia prevalences. Actually, I didn't list out. We grouped all the chronic disease for the 2 waves as well. The most astonishing increase in the prevalence of disease is cancer, especially in the younger. It's not the oldest old group, but the younger old group as well. So the chronic disease might be one contribution to this severe mobility. For the oldest old group is the dementia and Alzheimer rate is being increasing. It's doubled like in 5 years' time compared with 2006 when they did in 2010. Other disease like cancer and stuff probably will be some reason, will contribute to the reason why there's a severe disability status in this age groups.
Yeah, I think in the U.S. the primary suspect is rising obesity, but in China it may be smoking rates going up.
Smoking,
in the,
yeah.
in
Yeah,
the
lung
past.
cancer and the cancer rate in 2010 for men in certain age group tripled by compared to 10 years ago. That was really amazing. We tried to do another paper on that because that's really too astonishing to find this cancer rate such a big increase.
Okay, I think I will thank our presenter and discussant again for an excellent session. Thank you.